We are a committee of health. Our duty is to do oversight on the Department of Health, and we also are responsible for public participation. So, re tlile today because re ka public participation. I hope they have distributed the earphones because we often run our meeting in English and we have channels. That will be one is English. Let's already the earphone. Bali file the earphone. Alina the earphone. Okay. Are feng badi baba re thusang gore ba le fe di earphone ke tlo le fa di channels gore one e kae two ke eng so that le dieng ka mo ditsebeng le kgone o tuna gore re utlwane akere. Yeah, so can you please distribute these gadgets to members of community so that we are together? Those who can understand English, those who cannot speak English, raise your hand, then you can get this. But those who understand English, we are going to be speaking in English. Give community members these things so that we are together. We start at 10, it's already 10 past 10. They must take also. Hansat, can you please assist? We do have this, we are not using them. Give to the people who cannot speak English this, please. We have two here that we are not using. That's not, they are wasting. Hansat, can you please take these gadgets? We are not using them here on the table. Why didn't? We are starting with our meeting now. You are all welcome to today's meeting. I am Member Dikhamela. I am the chairperson of the Portfolio Committee of Health in Gauteng. On virtual platform, I have Member Bloom. I also have Member Mabunda already. So the three of us, we make a quorum. We are expecting Member Fuchs, Member Mabala, and Member Masuku.
I'm in the meeting.
Join the Portfolio Committee also online.
In the meeting.
The gadgets that they gave you, you've got one is English, two is Afrikaans, three is Zulu, and four is Sotho. Sotho, maybe Setswana, Sepedi, everything, mo o bolelang or o buang, you'll get it on 4. So the meeting is now opened and in session. So we are now going to the item of apologies. Do we have any apologies, Tembi? Okay. Ms. August will tell us if we do have apologies.
Good morning, Honorable Chairperson and Honorable members and the department. We did not receive any apologies for today. The other members will be joining the meeting virtually. Thank you.
Okay, on the issue of introduction, I want to go a little bit back. As a committee, we do have Non-Dumiso August is a committee coordinator, and then we have Tembim Somi is the administrator of the committee. Wakilen Zibande, I think he's busy trying to arrange the table. And also Isaac Ngobo, he's busy distributing the gadgets, assisting the Hansat. So that is part of our committee, plus the honorable members that I have mentioned, they're online. We are also today having the MEC of Health, MEC Mokheti. I'm going to ask MEC to introduce the team that he is with in this meeting. He can ask them to stand up. As a committee, we are not too many, but the MEC will tell you who is here. MEC, over to you.
Thank you very much, Chairperson, HOD and colleagues. I'm going to request that the HOD introduce the colleagues because we are here with a very big team. Over to you, HOD.
Thank you very much, Chairperson. I'm going to request that I stand up and stand up with my team. I'm Sibongile Zungu, the acting head of department, and all of us from Department of Health will stand up. Chair, it will take a lot of time to introduce each person, so it's all of us here. Okay. Chairperson, it's a lot of us who are here from the department. It will take a lot of time to introduce everybody, but the DDGs in the department are here, from the Chief of Operations, the DDG Clinical, and we have also the Chief Risk Officer, we have Strategic Planning, and we have Legal Services, and we have the CEO of Dr. George Mukari Hospital acting, who is also the Chief of Nursing in the department. And it's just a lot of us here, Chair. And even infrastructure is here, right in front of us. Thank you, Chair.
Thank you very much, Dr. Zungu, for introducing your team. Our agenda is not very long. We've got presentation by the Department of Health on the annual report for 2020-2021 financial year. Can I ask that we keep quiet so that we are able to hear? Can we keep quiet and make sure we've got our masks well applied to our nose and our mouth, please? So we've got only 3 items today that we will deal with in this meeting. The first one is the Department of Health annual report, and the second item for this meeting will be a second quarter report from the Department of Health, which is 2021-2022 financial year, and there will be presentation also on COVID-19 update. Then the other items is for us without the department. There are not many. I'm going to ask honorable members on the platform to move for the adoption of the agenda for today's meeting. I know Honorable Fuchs and Honorable Mabunda are in the in the platform. Can I get the indication from yourselves that you adopt the agenda for today's meeting?
Madam Chair, Member Bloom, I move to adopt the agenda.
Thank you very much, Honorable Bloom. Any seconder for the agenda? Member Babunda? Who else is there?
It's Member Mabala. I will second the adoption of the agenda, Chair, and please acknowledge my presence. Thank you.
Thank you very much, Honorable Mabala. We mentioned earlier that you will be in the meeting. Thank you for adopting the agenda. Thank you very much. Now we are moving to the presentation by the Department of Health on the annual report. That will be followed by the quarterly report. MEC, over to you.
Thank you very much, Honorable Chairperson, and sanibonani bahlali baseBurgettdal. Ninjani? As a Department of Health, niphathele annual report. Sizoreporta futhi ngange-quarterly report. So mase siqede ukupresenta nizokwazi ukuthi nibuze la nibuza khona. Ngizonikela ku HOD ukuthi asitshele ukuthi abobani abazopresenta from the department. Thank you, Chair.
Thank you, Chairperson, and also thank you to our MEC from the department for the first two items that the Chair mentioned, being the quarterly report and firstly the annual report, then the quarterly report. We have Ms. Adelekan that will present, and on the update on COVID-19, it will be the COO, Mr. Malotana, that will present. Thank you, MEC.
Thank you, Honorable Chair and Honorable Members, MEC, HOD, the leadership of health, and our community at large. Can I request, Honorable Chair, that should I sit that side? Okay.
How are you?
I'm fine.
I'm all right. Just present as normal, but just be as close as possible as you can to the
Okay,
mic.
all right.
And then, yeah. Thank you.
Okay, thank you. Thank you, Honorable Chair. Once again, I'm going to be presenting on the Gauteng Department of Health annual report. There's the outline of the presentation. The 2020-2021 financial year is a period that coincided with COVID-19. As most of us know that the events that came about because of COVID-19 resulted in a lot of lockdowns, which just basically reduced mobility and even ability of people to move to healthcare facilities. And with the emergence of COVID-19, we saw a number of patients that we would normally see on an annual basis declining. So people basically reduced their movement to primary healthcare facilities as well as our clinics. And that also, ultimately affected the type of performance that we were hoping for. So as a result, you would see that the performance of the department overall declined by 15% as a result of the COVID-19 pandemic and the associated restrictions that it came with. We, however, still aspired as a department to continue to be responsive, to be people-centered, to put you as the communities of Gauteng at the center of all that we do. So we continued with the implementation of interventions that are aimed at reducing the number of mothers or pregnant mothers that die during childbirth. We also implemented interventions that are aimed at reducing the number of children that die at birth or that die before they reach 5 years of age. With regards to that, we saw that whilst we were able to keep the number of children that would have died due to pneumonia and due to diarrhea below target, we were not able to succeed with regards to reducing the number of mothers that would die, during pregnancy. As far as communicable conditions are concerned, we also continued with our efforts to address communicable conditions like HIV and AIDS, basically implementing interventions that are aimed at preventing people from contracting HIV and at the same time contracting tuberculosis. We have done very well in terms of ensuring that we are able to detect, even during COVID, TB, DRTB, and we were able to successfully treat 60.2% of the people that were put on treatment. Even though, because of COVID, we were able to test fewer numbers of people for HIV, we have managed within the financial year to test over 4.3 million people for HIV. This is a very important target for us because ultimately we would want to have people that not only know their status, but those that know their status can then be, put on treatment and be supported by the very department. Due to lockdowns, we also had certain benefits in that the people that would normally move from malaria endemic areas or areas that are commonly known to have high malaria cases were restricted, in their movement. As a result, the number of people that died due to malaria in our hospitals was significantly reduced. In terms of non-communicable conditions or conditions such as your chronic diseases of lifestyle, your diabetes, and hypertension, we continue to implement health education programs that helped us to reach over 3.7 million people on various aspects of how to maintain a healthy lifestyle. We have also, in terms of ensuring that people can access healthcare services even beyond normal working hours, we were able to increase our community healthcare facilities that offers 24-hour services to 36. So to 34. We currently have 34 community health centers that people beyond 7 o'clock can always go to access care. We are also mindful of the fact that we don't just want to increase the numbers of the facilities that offer care, but we also want to improve the quality of care that is provided in those particular facilities. So on a quarterly, on an annual basis, we were assessing the readiness or even the quality of care that is being offered by these particular facilities. And we found that of the 356 clinics that were assessed, we had 317 of those meeting the ideal clinic standards, meaning if we were to implement national health insurance, our clinics would be part and parcel of the facilities that would be accredited as quality facilities. We also, in terms of making sure that we improve on our leadership and governance, we continued also to make sure that posts, there's movement in terms of filling of various positions. We struggled a bit, of course, in terms of ensuring that there is sustainability in terms of the functionality of our clinic committees. Our hospitals committees or governance structures did function, but it wasn't at an optimal level. Over and above all these activities that we render in our facilities, we also want to, we've implemented interventions that are aimed at improving efficiency. Why is it important? We don't want people to come to our facilities and wait forever for their patient records. That is why the department saw it fit to start an intervention that is aimed at digitizing or automating your patient record so that your patient record can be accessible on an electronic platform. At some point, we'd want you to have access to some of these things on your phones, on your tablet, so that you can begin to understand exactly, what your health status look like and work together with us as the healthcare system to make sure that we maintain a positive health status of everyone in Gauteng. So in terms of those particular interventions, we continue with the implementation of the health information system and automation of the various business processes. We've also, because of COVID, had to implement a number of measures to make sure that we increase the number of beds, across the various facilities. And we'll see also as we present the Q2 report, some of those interventions and how they've benefited yourselves as communities and some of the members of the communities that had to be admitted at such facilities. Health systems are human resource intensive. For you to get care, there has to be a nurse, there has to be a cleaner, there has to be a doctor, there has to be allied health professionals. So all in all, for the past year, the total workforce in Gauteng was over 81,000 with various categories of personnel ranging from specialists to support staff. And with those particular support staff and specialist personnel, we were able to offer a range of services. I'm sorry that this looks a bit small, but just to give you an idea of a range of services that we provide, we're able to, as and when pregnant women came to our facilities, we're able to, attend to them. For example, in terms of children under 1 year, we're able to immunize over 217,000 children that came through our facilities. We're able to see over 259,000 women that came for, antenatal healthcare services. We're able to also provide, HIV testing, your TB testing. We're able to make sure that those who uses chronic medicines, who are stable on chronic medicines, over 1 million of them, don't have to go and queue at clinics or hospitals, but they can go to the nearest store or go to the nearest center where they can get, their chronic medication. In terms of expenditure, all these services cost money. The people that the number of personnel that we've put up, over 81,000, do cost money, and we're able to spend over 57 billion, across all the different services that we are rendering both at our hospitals and our clinics. Earlier on, I did indicate that this annual report period did coincide with COVID, and as a result, we had to, basically our performance reduced significantly to 55% from 64% that was reported in the previous year. There are a number of programs, again, within the department that we just want to give you a sense of how we've performed and how we've used the resources that we were given. In terms of facilities, making sure that our facilities are safe and are compliant with occupational health and safety, there is a number of interventions that are being implemented from an infrastructure point of view and also from an occupational health hygiene kind of point of view. And there are assessments that are continually being done. At this point, we largely focusing on assessments that are aimed at managing the hazard risks that are associated with occupational health. And with regards to that, we were able to exceed our target. We were also able to reduce the number of the amount of money that we spend on medical litigation. Because if this amount are not kept, we will end up not having money to provide care to the rest of the community. So there is mediation related interventions that are being implemented to make sure that we don't pay unduly where we're not supposed to, pay. And as far as making sure that the healthcare system also contributes to economic development and economic growth within Gauteng, we do also encourage as a department that we, provide access, for growth, for economic growth to the communities around. So in terms of that, we're able to have 29% of the goods and services money in the department spent on building township economy. With regards to ICT, we had a number of delays in terms of contracting. As a result, we were only able to start or commence with the health information system that would see you having your electronic health record across all our, clinics. There were a number of delays in the other areas, so we're not able to perform better in such areas. We also continue to work on improving and minimizing waiting times across all our facilities, and hence we are implementing what we call a lean management program, so that when you go and get your medicines at the hospitals, you don't have to wait too long at your pharmacies. When you go to your registration departments to get your patient records, you don't also have to wait for too long. In terms of increasing access to care, as I said earlier on, we have 34 CHCs, and these CHCs and clinics overall are assessed to make sure that they, are accredited as ideal facilities. We also take into consideration all the complaints that you provide to us. As a result, 95%. 88% of the complaints that were received were resolved. Unfortunately, we were not able to resolve the up to 95% of the expected complaints because of the human resource challenges that we had also during COVID, where some of the units had to be reconfigured to cater for COVID. In terms of functionality of structures, we need to obviously do a bit more with clinic committees, and also in terms of hospital committees, participation and functionality also declined there. And we're hoping that, in the coming year, things would have improved. In terms of making sure that people understand their HIV status and that people can be retained in care, we were able to exceed our target for HIV testing. We were also able to make sure that the positivity rate for the 15 to 24 years is also maintained within a target. What I want to emphasize, however, is that once people are placed on treatment, we're having challenges as a department in making sure that people can take their treatment as they're supposed to take it. Because if treatment is not taken appropriately, if people don't pan out at our facilities on the days that they are given, that ultimately affects their ability to suppress the viral load. And that is, it's for that reason that we also still having challenges. Whilst we've done relatively well in making sure that a significant number of over 4 million people know their status, that over 1 million people are put on treatment, on HIV treatment, we're having challenges that people are not being virally suppressed. So this is an area that would like to encourage our communities to make sure that not only for adults, but also if you are a caregiver of an HIV positive child, that you please help work together and partner with us as a healthcare system to make sure that these children are brought, for assessment, and they take their treatment as, they're supposed to take it. We're also having challenges in terms of adult clients that are remaining in care. Although we have over 1 million clients that are remaining in care, also over 21,000 children that are remaining on ART care. We also have found that when we want to follow up on those of the clients that are not coming through to facilities for assessment, we are not able to find such clients because they had given us incorrect addresses. So we want again to emphasize the importance of providing appropriate addresses so that when we do follow up for those clients that are lost to follow up, we can find those particular clients. The same challenge is with regards to lost to follow up in tuberculosis. We have managed to ensure that clients that are diagnosed with TB can be, can successfully complete their treatment. But once again, we still have challenges with regards to clients that default, on treatment. Once again, we would want again to emphasize the importance of making sure that once people are on treatment, they can then complete their treatment. We've seen, because of COVID again, we've seen a spike in the pregnancies, 10 to 19-year-old pregnancies. We have also seen some improvements, of course, in terms of our provision of contraceptives. But however, we've seen that there are certain, declines or shortages in, accessibility of some of the, contraceptives, particularly the, the injectables. In terms of antenatal healthcare visit, this is another measurement that we track, that we always emphasize that pregnant women must come to our facilities before they reach 20 weeks of their pregnancy or 20 weeks of gestation. Why is it important? It's because this is an area that if a mother has a high-risk pregnancy, the healthcare facilities can help earlier to intervene and prevent unnecessary deaths of the mother or of the child. So for the year under review, whilst we didn't reach our target, we have been able to see at least 63% of these women that came for antenatal care visit, and we'll continue to encourage communities to make sure that as soon as a mother, a woman, or a young lady sees that they've missed their period, they should immediately go for a pregnancy test. We offer such pregnancy tests also through our ward-based outreach teams. We don't turn away teenagers that are pregnant, but we do make sure that they are attended to by skilled birth attendants. And for the year under review, we were able to have 8.9% of these teenagers being delivered by skilled birth attendants. But while that is the case, this is a social misnomer, and it's something that we're tackling, and we need also community leaders also to work together with us and Department of Education to make sure that we empower our young people, to help prevent, untimely pregnancies. In terms of mothers that have already delivered, we do provide care, because there is a chance also that mothers do die, even their babies do die after pregnancy. So 6 days after they've delivered, they need to still come to our facilities so that we can then help assess them. In terms of that, we have managed to see 75% of mothers that for every live birth that we had. In terms of delivering of babies that are low birth for weight, meaning babies that were born smaller, for their age, we were able to, for the year, we had 13% low birth weight, which is also below the planned annual target of 13.5, which is something that we would want. We don't want to have a lot of babies being born, low birth weight. In terms of preventing HIV from the mother to the child, we saw that in terms of the program that we've implemented called PMTCT, we were able to make sure that babies that are born to mothers that are HIV positive, when tested around, 10 weeks, we were able to, basically maintain that positivity rate below the expected threshold. We're still having challenges in terms of neonatal deaths. We saw during COVID that over and above having mothers dying last year at a significantly higher levels, we also had a certain number of children dying, like 3,161 neonates, babies dying due to various challenges. We've also saw that we had challenges also around maintaining diarrhea rate below the threshold. We have, however, managed to get those children that suffered from pneumonia, basically maintaining or minimizing a number of them from dying. So case fatality rate due to SAM, meaning children that die due to malnutrition, we saw an increase in these particular numbers, and for the past year we had 9.2% of children dying from severe acute malnutrition. So basically, by the time these children came to our facilities, they were already not failing to thrive. They were already malnourished. Yeah. Overall, the deaths under 5 years against live birth was at 1.7%. And again, this also shows that we had a slightly higher numbers of children under 5, dying. We continue, however, to provide supplements to children. The vitamin A doses are proven worldwide to be effective in helping boost the immunity of children. So we would encourage mothers of children that are no longer under 1 year, that as soon as this child goes to the crèche, or as soon as this child is beyond a year old, that these children should be given this vitamin A supplements. And in terms of that, we still are way below a target at 47%. Immunizing children is very important because these are interventions that are cost effective and that are very effective to prevent children from dying before they reach 5 years. We were not able to do well in the past year. We have 85% of children immunized under 1. We are also not able to do well in terms of measles, where we had 77% of children instead of 90%. So these are very important or critical areas that would like mothers or caregivers in the room to take note of and to help us make sure that we improve our coverage on immunization of these particular children. We implement programs as well that are not only aimed at people that come to our facilities sick, but we also implement programs that will enable our children to learn better, in schools. In that regard, while we implemented some of these interventions, screening interventions at the various schools, we still had, obviously interruptions due to COVID. So, but for school grade 1 learners, we were able to screen 17,000 children in grade 1, as well as 4,900 children in grade 8. We maintained malaria deaths in check. We also continued providing, education, various types of education to communities. And we continue to monitor for those that are diabetic. We continue to also monitor whether that diabetes is being controlled, whether the people that are on treatment are managing their diabetes better. And in terms of that, we want to make sure that there is improvement in the management of that particular ailment. We also have done very well. I'm sure you've seen our health workers going from house to house, even calling you in terms of just checking whether you were exposed to a COVID positive person. We've done very well in terms of that, making sure that COVID doesn't spread like wildfire. We continue also to provide emergency services through our emergency vehicles or ambulances. And we have made sure that we can respond to emergency calls, on time. We've done very well in terms of those particular calls responded to within 60 minutes, and those that were made within, 30 minutes. One area that I want to just emphasize here is the concern regarding the attacks on our EMS staff, that would want to encourage us that these are resources that are available for you to make sure that you can be transported when extremely sick to the next facility. So let's make sure that as communities we do protect these particular assets, because they are our assets. In terms of hospitals, because again of COVID, we started seeing that a number of people that would normally come to our institutions were not coming, and as a result we had a decline in our OPD numbers. And we also saw that whilst mortality for mothers increased, the increase was much more pronounced at our regional, hospitals. And in terms of child diarrhea cases, we also saw that we had district, regional, and our central hospitals having, the most cases. And in terms of pneumonia, those that died, we also saw a pattern that these children were also RVD or HIV positive, over and above having COVID, complications. With regards to some, a large number of these children presented at our central and regional hospitals, which contributed to 68% of the deaths that we saw. And overall deaths under 5, we saw that again our central and regional hospitals, and you can ask why central and regional hospitals are mostly affected. These are hospitals that provide specialist care, so a lot of the children or caregivers would likely then to go to these particular facilities. As far as ideal hospital status, which is aimed at improving quality of care, we have done also, relatively well with that. As and when there are incidences, in our facilities, we also make sure that these incidents, whether harmful incidents, can be reported within within 24 hours. So please be rest assured that we do attend to every of these cases, incidents that are reported, or patient safety incidents, because we are all about making sure that yourselves as communities, when you get to our facilities, are admitted in our hospitals, you can be assured of your safety and your well-being. With regards to understanding what your needs are on an annual basis, again, we do a client satisfaction survey, and in terms of that, we have done relatively very well, actually, not relative, across all our institutions. And all the feedback that you do give, we transform those into interventions that are aimed at improving areas of concern that you're raising, like your, complaints that have been coming through on waiting times. We also do assess expectations of our own employees, and we're able to have 59% of the employees satisfied with the way the department is, and we're at the same time also addressing some of the issues that the employees are raising. In terms of making sure that there's medicines at our hospitals and our clinics, we do maintain a 97% vital medicine availability and 95% essential medicines. We have over 1 million clients that are currently enrolled in our chronic medicines program. We've also made sure that we can provide, work together with our laboratories to make sure that we provide COVID results on time. Whilst we didn't reach our targets in terms of our health infrastructure, we were, however, be able to, increase the number of beds that were meant to help with COVID clients. We are also able to have facilities like the field hospitals, should we have had, an astounding number of COVID cases. In terms of expenditure for the year, we were able to spend 98.1% of our budget, and we're within the straight line norm. There were obviously, certain reasons why there was a bit of under expenditure in some areas, or over expenditure in certain areas, but in terms of administration, which is where a lot of our employees are paid, we were able to spend fully there. In terms of areas where we had a number of challenges, it's with regards to governance-related issues, and that is audit-related matters, where from the Auditor General's point of view, whilst we've got an unqualified audit opinion on our finances, in terms of the reliability of our predetermined objectives, we were found to have an adverse opinion. So maybe let me just skip there and go there to the areas of findings that auditors did speak to. Within human resources, we are addressing challenges relating to the organizational structure. We have been able to submit the draft structure with the MEC approval to get additional inputs. We have also started putting measures in place to make sure that we address approval of leave forms, including whatever overpayments on terminated employees. In terms of expenditure, we're working hard as well to make sure that we improve our processes so that suppliers can be paid within 30 days. We're working hard also in terms of our contract management processes so that we can then also reduce our irregular and wasteful expenditures. And at the same time, we're also through our automation of business processes, making sure that we can attend to the challenges relating to, medical records. So these are just some of the audit findings that the Auditor General did find for the year under review. We needed to also address matters relating to how we manage our assets within our various facilities, particularly movable, assets. In terms of ICT, we're improving our ICT, governance, and there is a number of initiatives that are already being implemented to make sure that we improve those particular areas, including attending to whatever risks, operational risks that are inherent within our ICT, making sure that we provide we protect the information or the personal information that you've provided to us, and making sure that we've got adequate risk mitigation strategies that will ensure that should the facilities or institutions ban that the information is stored, outside of those particular facilities, and is basically retrievable in time for proper business continuity. Within SCM, we are also addressing some of the governance challenges, as well as PFMA compliance, of making sure that we follow the rules and regulations that are outlined within the PFMA. We had a number of challenges also relating to procuring goods within the required costs, and those areas are also being addressed. In terms of audit of non-financial information, we also are addressing challenges with regards to our records at our facilities. When you come to our facilities, please don't take your patient record with. It's for the facility, so that when auditors come, they're able to find it. So we are addressing some of those particular challenges, and most importantly, making sure that the information that is provided to yourselves and to the legislature is reliable. So in conclusion, Chair, I think the department has done its best during the year under review, which was marred by a COVID pandemic. There's a lot of work and effort that was put forward by our frontline workers to make sure that COVID patients, and also patients that presented to our facilities without COVID, can be attended to. We have a lot of lessons that we've learned during this particular period, and we are also able to innovate to make sure that patients don't even have to come to our OPD, outpatient departments in our hospitals, to collect medicines, and can collect that particular medicines outside. So there is indeed a lot of lessons that we have learned that we are using to improve our current processes in the department. So although there was a slow pace in terms of attainment of the various performance targets, we want to leave our people with this message that we remain committed to making sure that we continue providing the care that is of quality to yourselves. Thank you, Chair.
Thank you very much. It was too long now. Thank you very much for ending there and the information that we have provided. Let's move now to the second quarter report, so that when it's time for questions, we only go once to the questions, because this one is too long. In class, people fail if you speak alone for this long. Can we get the second quarter report, MEC? Who's going to do the presentation? Can we at least get a summary of this one. Thank you, MEC.
Thank you very much, Chair Zulu. Will summarize that, and then the COO will do the COVID. Thank you.
Just do summary, please. Otherwise, these people, they are not even listening.
That's fine. Thank you, Chair. I will just summarize because it's continuation of the previous year. So for Q2 is basically the last 3 quarters of the current financial year. And I'm just going to tackle the first few slides, which looks at the summary. In terms of our performance on administration, we are expected to have at least 48% of our human resource senior managers comprising of female candidates. And we've done relatively well. We at 48%. We of course aspire to move to 50% as per the national guide. We have also 90% of our hospitals complying with occupational health standards on the administrative side, of course. And then in terms of the targets that were not met, in terms of administration, it's areas relating to the spend or the amount of funds that we spent on improving economic development of our townships, as well as making sure that we are able to reduce our medical litigations. In terms of Program 2, which is another program that we render, we have ensured that we can increase community health centers that provide care over 24 hours at 36 of our CHCs, and we've also made sure that clinics that provide care to you are accredited in large numbers as ideal. In terms of preventing conditions and improving the livelihood of or longevity of the children or survival of the children, we have continued also to attend to various childhood conditions, and as a result, we have also seen some improvements in terms of those particular areas, like diarrhea case fatality rate was maintained at 1.8%. We've also made sure that in terms of PCR testing as well, that we have a significant number of children that are born to HIV positive mothers testing negative. We have, from various programs that we implement, we have also exceeded our targets for HIV testing. We have, unlike the previous year, we have managed to also have a significant number of adults that are on HIV treatment being virally suppressed. We just need to still work a bit more on children viral suppression. We unfortunately again still have challenges with regards to curbing maternal mortality, so again we emphasize the importance of visiting our facilities as and when you see that a person is pregnant. They need to be at our facilities to make sure that we can then identify potential problems that might arise during childbirth earlier on. In terms of areas that we're not still performing quite well on is with regards to immunization under 1 and our measles targets. So we again encourage communities to please come through with those children so that children can be immunized. We've done well in terms of making sure that we respond to EMS calls. All the priority 1 calls targets were met. But we obviously still need to improve on some of the processes between facilities. We have seen significant improvement in our interventions, in the implementation of our interventions and programs, from 55% to 57% in the year under review. and that also gives us hope that there is a light at the end of the tunnel, and we're hoping that by end of the financial year, in terms of these particular programs, we would have improved quite significantly. So that's basically the summary for this particular presentation. I'm not going to go into details in terms of the trends that we had put up. We had also, I think in the previous quarter, we were asked to also talk to functionality of our health facilities. Chair, we have provided those particular slides for the benefit of the members so that you can see the kind of areas or, that makes the 24-hour CHC functional. We continue also to monitor our PSIs, and we are also aware of areas that we need to intervene. We monitor also the type and the nature of complaints that our communities provide, and we are aware of the top areas that needs to be addressed, which talks to staff attitude, which also talks to access to information. So those particular areas, we are currently working very hard, on them. So there is a number of recommendations that are also provided on the slides, but I think what gives us assurance, Chair, is the fact that we have seen some improvements for the second quarter, and we're confident that come end of the fourth quarter, we would have moved even further. Thank you, Chair.
Thank you very much. Can we stand up for a minute and stretch ourselves? We can do this and do this. Yeah. And do this. That class was too long. Very long class. Can we now take the last presentation? Mr. Lisiba Malotana is going to tell us about the COVID report. Thank you.
Is it saved here? Honorable Chair, members of the committee, MEC, HOD and colleagues and the community of Westonaria. Ke tlo ira presentation ya COVID-19 and ke tla just hold bontsha di number di patients tse re nang le tsona kwa dipetlele le gore re bereka bang as far as the plans tša COVID-19 le the fourth wave. So nationally, I think we botlhokwa go notice the number of infections nationally, as in the last 24 hours, recorded 687 cases, and that is as far as the number of active cases we have is now 19,147, with 96.3% recovery. Recorded death only say 2 in the last 24 hours. What's important is out of those 687 cases, most of those the infections, they are located in Gauteng. So recognize Gauteng as a province, ke re na le infections tse dintsi go feta everybody else. Slide is really go bontsha gore mo re tswa kae ka wave 1, wave 2, wave 3. Mo go leng bo blue ke dinomoro tse leng tsa Gauteng. What's important ke the bottom of the slide go bontsha gore the number of infections di a thoma go namella gape mo Gauteng as a province, and that's the biggest concern e re nang le yona. As things stand, we are sitting with 2.9 million confirmed cases. This is the since record COVID-19. As far as the death, 3.1% of the total number. That's 89,000, including more fela the number of cases in the province, and I think the first buy it little ke yona bontshang gore Gauteng ke yona ngena le the highest number is le ka bona the high ka botelle ba the mara le other provinces o tshwana le Northern Cape, Mpumalanga, Western Cape le tsona mara nomoro tsa bona ha di tshwane le tsa rena. As a province, over the 600 and something cases, 545 of those are Gauteng, and Kiona the biggest concern. And maybe as far as the practicing the non-pharmaceutical intervention, social distancing, continuing of wearing of masks. So the number of infections out of the 600 and odd, 545 of those are in Gauteng in the last 24 hours, and that's taking us to 923,379 as far as the cases. We are sitting at 98% recovery rate. More the same thing as far as the epidemic the number of infections the wave 1, wave 2, wave 3 di fast mara re a thoma at the beginning increase the number, and ke ntho e leng gore yona re tlisa mo gore re be attention to the numbers of infection. More number of cases ka di district, the cases ke tse dintsi in Tshwane followed by Johannesburg. Most of the cases reported currently, 64.7 of them are in Tshwane, and in numbers the university is one of the biggest contributors to the number of infections that we have in the province. Here we have the sub-district, and same thing here, Tshwane 3, Tshwane 1, Tshwane 6, including some of the sub-districts that Johannesburg continues to be the biggest contributors to the number of infection. More weekly comparison, you can see as far as the weekly comparison is concerned, persistently Tshwane 1, 6, 4, and 2 ke yona leading infections of everybody else. Mara the rest of the province ha ena infection e ra hore fela go Tshwane in the last 7 days the increases of everybody else. Miracle as far as we reduce the transmission, go bontsha hore every day miracle screener and testing that continues to be done on an everyday basis, and of course those that qualify for testing ba testiwa. More the intervention the department le other government agencies di dirang as far as suppress the infection, mo visitor the long-term care facilities, mo nang le old age homes, who screen batho ba tsenang through the airport, who visit the community screening and the compliance the businesses they visit you who check or not they comply or not. This is what we call the word-based battle plan. The more the infection department rumela part at the sub-district level who visit our education, public awareness, and of course the screening and testing. More the battle plan in terms of the screening and testing that gets done over and above just COVID-19. They tester for TB, chronic medication, hypertension, and other conditions. That's the department. Contact tracing, as far as the contact tracing is concerned, the department did tracing based on the index cases that are reported. This is the slide ne ke bolela ka sona earlier hore in the past couple of weeks, noticed the infections go University of Pretoria and Tshwane University of Technology, University of Pretoria having 13 students that tested, and of course Tshwane University of Technology 33. These are of course the contributing the spike in the number of cases as far as the infections go Tshwane. Maybe the patients that are admitted. More the number of patients that have been decreasing drastically from we at some point we had 4,000 patients in our system. Today we are sitting with only 540, and as public or government reducing the patients only 217. So the number of patients in the system are very low compared to Morojoang, and just based on their conditions. Le ba re nang le bona ke ba ba nang le maybe the long COVID or comorbidities are dilo tse ding. Ye ke dashboard ye re berekisang go department to monitor the number of beds e re nang le yona le a kgona go bona gore if this was a will, we are even less than half of that. So meaning that as things stand who accommodate the patients and over 3,219 beds ye re ka di berekisang. The beds tse di a bontsha gore admission over time wave 1, wave 2, wave 3, nearly they had the longest, the biggest, those admission, the number of patients in and this is the same information that ones are different in terms of the admission over time. The lowest numbers modeling currently and it will improve. Moria boncha hore na le di bed tse re creatileng go the structures they were bitsang ABTs, and re boncha hore le tsona as things stands most of them di na le very minimal patients re na le capacity ya go accommodate the patient should hore e ka tlhoke. Maybe check it like the last two slides just to want we are monitoring also the health worker infections. Over time, of course, over 16,258 health workers have been infected. In the last 24 hours, only 7 infections were recorded, and those includes those that are in the public and one babaling, and we only lost one health worker in the last 24 hours. So as far as health worker infections, we are reporting just one additional one. Chair, maybe we are going to have just from a forensic measure, renal capacity, ya accommodate should the need arise 62 and 17%.
Hello, la raza mo hodimo mo. La raza. Why?
Okay, thanks, Chair. Maybe a summary, Chair, as I conclude, a number of infections in the past week has slightly increased. There's a decrease in the number of patients that have been admitted. The test positivity rate in the recent weeks nearly very low is starting to pick up as our number of infections they increase. In terms of hospitalization, Leona, we are starting to see an increase of 3% in the past 7 days. And this, of course, influences the number of total cases. Maybe, Chair, as a concluder from the scientist and the recommendation maybe will be presented to the committee and the community, the interventions, the non-pharmaceutical intervention, must continue to do social distancing and all those, they continue to remain applicable, and Chair everybody to note and continue to do the same practice. Chair, thanks so much, Chair.
Thank you very much, Mr. Malotana, for that presentation. I'm going to ask you to stand up as you prepare for questions, but we are going to take honorable members first. Can we stand up and stretch? better than nothing. Thank you very much, honorable members. Can I take hands from yourselves first to comment on the presentation? The three of them. You can indicate which one you are talking to, and then followed by the next one. I know Honorable Bloom, Honorable Mabala, they are in the meeting. And I know Honorable Fuchs is in the meeting. So I'll take first Honorable Bloom, followed by Honorable Fuchs, and then Honorable Mabunda. You will follow in that order. Number one.
Thank you, Madam Chair. Just on the COVID presentation, just a comment on the accuracy of figures. At one stage, there were way more people given in hospitals than there were actually active cases. Then in the last 2 weeks, we had a sudden downturn in hospital cases. It just seemed to me that there were backlog reporting, that we were not getting real-time figures, that in fact we could tighten up on the accuracy of hospital figures in particular. But secondly, there was a slide which I don't see here, but I saw it in the one that was emailed to us, that that more than a third of our healthcare workers are not vaccinated. I mean, now that's of great concern. Is there a particular reason for it? I know we've got vaccine hesitancy in the broader population, but you'd think that health workers are under particular threat. They're educated, and I think in a medical setting it's particularly important that they are vaccinated. Can you just confirm that figure? As I said, I saw it in another slide. I think it's very concerning if well over a third of our health workers are not vaccinated. Thank you.
Chair, thank you very much. In terms of the annual report, I'm really concerned to see that when it comes to maternal and child deaths in our facilities, we are not meeting our targets. And that seems to be the case across the board. Now, Chair, it was pointed out that we need to be clear as to what contribution COVID made to those particular statistics. And so my question really is to the department, do they keep track in terms of the maternal and child deaths as to what extent COVID actually played a role? And so I'd like a response in terms of that particular question, please. And then secondly, Chair, once again, also on the annual report, we have over a period of time raised numerous concerns about the inability of the health department to manage its infrastructure, its facilities, and also to provide oversight over the activities of the infrastructure development department. It seems as if we do not hold them to account. We have many of our facilities where we don't meet deadlines in terms of time, and we don't, we spend more money than we should on these particular facilities. And I'm not seeing anything, Chair, from the management, both political and administrative, in the department. I see no interventions in trying to deal with that particular matter. We just roll along, accept the status quo, and that is problematical, Chair. We need the department to come up with an intervention which would satisfy the committee that the department has the necessary skills and resources to manage the implementation of infrastructure, because as we currently stand, that is definitely not the case. Thank you, Chair.
Thank you very much, Honorable Fuchs. Can I welcome Honorable Mabunda?
Thank you, Chair. On the annual report, my first take will be that probably in future, Chair, I think it's unfair to subject the committee to 108 slides Rather, there must be a way in which the department can summarize the presentation to the committee. Because the reports get given to the committee. If there's anything that we need to look into, we can just raise those issues rather than presenting 108 slides. That takes an hour to present. But secondly, it's with regards to slide 15 that speak to the SCM strategy to promote township enterprises. I think it's an issue that we've been continuously speaking about. And the report also make mention that there is no substantive improvement to the much needed promotion of township enterprises. I think the department needs to look into an action plan that will have details and targets on how are they going to improve in that space. But secondly, in slide 21, the resolution of complaints within 25 days, we seem to be having an issue in that space, and I think it's an issue that the department must also give it considerable thought and give it attention. Because you can't have so much complaints and then they remain unresolved. It has an impact on the staff retention program. If the staff have complaints and they are not attended, it impacts on the morale of the staff and ultimately affect the service delivery that they are supposed to be giving to the health facility. And slide 22, also functioning board mostly speak to, and because of its non-functioning, it ultimately will also affect the operations in clinics and in hospitals. I think it's something that we must look for a sustainable intervention program. We have had suggestions in the previous meetings, but none of them seem to be taken into consideration or implemented. I think the department must also do something about it. The next will be slide 85 and 86 with regards to HR issues. Some or including the overpayment of terminated employees. I just don't understand how can that happen, that someone is terminated and we still pay that person or that employee. And also the deviation from SCM processes. Whilst there's a process of condonation, such should by all material terms be avoided as much as possible. And the last one on the COVID presentation, and I think it's not necessarily on the department side, but all of us as society and the community across the province and throughout the country, we seem to be lowering the guard with regards to preventative measures on the pandemic. But also including our communication strategy seem to suggest that the pandemic it's probably gone, or we don't give it a priority as we used to, which makes everyone to lower the guard. And by the statistic or the numbers that were presented today, it is clear that this pandemic is still with us and it still needs to be given its utmost attention. I think it's just the communication strategy that the department needs to relook into, just to re-advise or remind the communities that this pandemic is still with us. we still need to take reasonable steps to make sure that we protect each other through the use of sanitizers and the use of masks. Because if you walk or drive around the down townships, it will seem like there's no longer a pandemic by the way people are going on with their business without putting on a mask. And I think that's my conclusion. Thanks, Chair.
Thank you very much, Honorable Mabunda. Thank you, honorable members. Those were the only three who raised their hands. I'm now going to ask the members of community. Ke nako ya lena setjhaba hore le lena la kere le bone presentation e bontshitse hore department e bereka eng le eng le eng. And then ke nako ya lena hore le botsise di-question. Ke tlo khupela hore ha o nyoko emisa go bolela emisa letsogo ro fa sebaka gore o bolele. Ke tla thoma ka mo siteng e. Ka mo ke manyakang go bolela number 1. O number 1 is yes, bia letsogo. Number 2. Kamo ausana o anyo ko bolelang ka mo siteng e. Lishapo ke a feta ne. Ke tla ka mo siteng e. Number 2, ma'am, you are number 2. Yes, 2. Le lengwe letsogo. Was chaba. Orare presentation e 108 slides re complainang ka yona hore ba tlhole ba re fa too much. Ala bona se sengwe se le ka commentang ka sona. Oh, okay. It's fine. Kinale 1 and 2. But the helinale something le tla no bolela and then helinale something le tla no bolela and then re tla le fa chance because ke public participation akere. So helinale le public le sa bolele. O mara re tla no le bolelela ka hore rena re phela le bona akere. Mara we wish to see many hands. The tlo raise the question. So Dr. Zungu, there are questions from honorable members and then there are 2 members of public. Ge le tlo bolela wa bolela hore ko wena mang and then wa bolela. Dr. Zungu, over to you.
Thank you very much, Chairperson. We are here as a team, and I'm going to wrap up when my colleagues have finished responding to the questions. I'm going to request that Mr. Malotana responds to the issues of vaccination and the real-time figures in relation to vaccination. And then we will have Ms. Adelekan as well as supported by Mr. Malutane in responding to the annual report questions. Dr. Maseko will respond to the issues of infrastructure. And we are also going to have the CFO responding to the issues that relate to township enterprise and also relating to overpayments of terminated employees, deviation from supply chain management. And then I will then wrap up in if there are any gaps that are remaining, Chairperson. Thank you very much.
Thank you very much, Dr. Zungu, the HOD. Over to you, Mr. Malotana.
No, thanks, Chair. There are 2 or 3 questions that I'll combine and respond to. One is the question that by Member Bloom. Member Bloom is correct in twofold. As far as the issue about hospital data and real time. We have become aware there has been an issue about data cleanup that we are doing. And you will see that the real time, a number of hospital admission vis-a-vis what will be reported, there'll be a slight differences. That's part of the process that we're doing with data cleanup. It's the same with the number of daily infections that were reported in the past 2 weeks or so. There was a backlog as far as the reporting of some of the tests, so there has been some cleaning up exercise. So Member Bloom is correct. But the data we are presenting today is really the updated data as far as that's concerned. There has been a lag. The same also happens with the vaccine data and EVDS. There's always a slight difference between what we'll report and what will be actual on EVDS. There's about a 24-hour slight lag for data to reconcile and clean up, and that's been the trend. So we consider and agree. But as far as the number of admissions and infections are concerned, the numbers you are presented, that's almost real time, and that's where we are. We are equally concerned about the remaining health workers that also remain without having been vaccinated. Over and above, of course, the issues about vaccine hesitancy and choices, I think health workers has been given the first preference, and the fact that there's up to 33% that currently remains, as the report we received in the PDMCC yesterday, that there might be up to that number of health workers that has not been vaccinated. Is it a cause for concern? But there are GPG-wide strategies that have been agreed on to motivate, educate, and encourage health workers and GPG staff widely to take up the offer for to get themselves vaccinated. So there is a number. The number that Member Bloom is referring to, it might be the report, because it was not in my presentation, but I know that in the PDMCC yesterday, figures were actually reported, and that might be where the number is coming from. And I think the HOD, those are the two questions that I could respond to. I think as far as Member Mabuda is concerned, that position that he has articulated is the position of the department, that we are noticing that the society is COVID fatigue, that it's really getting complacent, and that it's probably at the dangerous time to be relaxing, given that we know what happens when the society relaxes, and then we are set back to another wave. So we are encouraged by the legislature's support on that. Thanks, HOD. Thanks, Chair.
Thank you very much. HOD, who is going to respond next?
Thank you, Chair. We are going to have both Ms. Adelekan as well as Dr. Maseko, and I also have Mr. Cave. I just couldn't see him. He was not within my, but Mr. Cave. Oh, there he is. Maybe he can come this side to also assist us on the issues of HR, where people that have left the department, they also get overpayments. And maybe just, I know I had said I'll wrap up at the end, but I would like to indicate that we had a situation where, because of the delays in the receipt of the tests of COVID-19, when you do the PCR and it takes long for the results to come back, the National Health Laboratory Service brought along the rapid test, the antigen test. Then the results that were coming from the antigen test, when that microbus goes to the community to do the test and you get the results after 20 to 30 minutes. Those results were not inserted into the results of the daily results of positive cases. And then what they have done is that they are now taking that backlog of cases, which is what is creating the problem of seeing a big number of positive cases and a disjuncture when you look at the active cases and the new cases the admitted cases. So that is something that is going to be stabilized. I'm hopeful that the Ministry of Health is going to make an announcement soon about the specific date where they will load all the backlog results, so that on that particular day we'll see the numbers going up, but it will just be for the record that there are so many people that have tested positive, be it PCR or antigen, and then from there we will be able to stabilize our statistics. I just thought immediately after the COO, I should just bring that into the fore, because our figures seem not to be tallying up, but that is the issue that we are dealing with. Thank you very much, Chair. I'm going to then request Mr. Delekan to touch on those issues, and then Mr. Cave will follow, and then Dr. Maseko will then follow on the infrastructure issues, and CFO will then be the last talking about township enterprise. Thank you, Chair.
Ms. Adelekan, you are welcome.
Thank you, Chair. The first question pertaining to challenges around maternal and child deaths, whether we keep these particular records. Yes, indeed, we do keep records at facility level of deaths due to where COVID was a contributory factor. There's M&M sessions or meetings that are held at unit level by our clinicians, and also at Hospital Exco, where a summary of these reports or cases are also addressed. We have our DCST teams that have also done studies pertaining to the cases, distribution of cases of maternal deaths, and the contribution that COVID has had on that. We can, through the MEC and HOD, share those particular reports with the House. With regards to the length of the presentation, certainly we are able to provide a summarized version of the report. What we'll do then going forward is to provide a summary and an annexure consisting of trends analysis for those members that would wish to understand the distribution, the geographic distribution of the various interventions and their outcomes. So we'll package those particular slides in that fashion going forward, Chair. I think Dr. Maseko can talk to infrastructure issues. And
Dr. Maseko, you're welcome.
Thank you, Chair. Good morning, Chair, members of the legislature and the community of Westonaria. I think, Member Fuchs, it was, I think, more of a comment which Member Fuchs has been expressing over the engagements that as a department we've been having in terms of just the outcome of the implementation process in infrastructure. But then there was a specific question in terms of what the department is doing around the relationship with the implementing agent. Maybe I'll start from the end. It is true that most of our delivery process at infrastructure has been plagued with various challenges as we have presented. But the most one has also been around the relationship from a service delivery agreement. The first service delivery agreement, which expired in 2021, 31st March, had a lot of challenges in terms of loopholes, also in terms of just the responsibilities and what each party, what is the it's responsible for. That has been then reviewed because the first point of call is really in terms of defining the relationship so that at least we are then able to be clear. So that has been reviewed, and it took a little bit of time in terms of certain clauses being discussed within that. But I'm happy to say the two HODs have since signed it. So it's in effect now as of the 22nd of October 2021. And it will be for 3 years. And it still then has a retrospective 1st of April 2021. So that's answering in terms of what is the department doing about it. And that can, Chair and members of it, that can be sent so that at least we are then able to see. The advantage of that is then that we will then be able to measure in terms of each from a department the responsibilities and the roles. And it will not be in terms of assumed. Now it will be that way. But also, there are then certain guidelines and frameworks that just come out of that a service delivery agreement, which is also going to be guiding in terms of how, just from a process of also just planning for infrastructure, so that at least that process is also protected, but it is also has got a lot of interrelations within the department, but also within the other spheres of government. And to that end, we then have had our first, in terms of a review or infrastructure workshop, where it had participants from all areas within the department, so that we are then able to then have from a planning or from the documents that are long-term in terms of what infrastructure we should put in and how we then need to enroll it. But if you also look at the SDA, we've also just engaged in terms of giving teeth to the department from a capacity point. Member Fuchs is correct that currently the capacity is not where it should be. The SDA does allow now that the department can be able to capacitate itself where it finds that the weakness or challenges. Should it be at a point of a program or a project management, or to a point of supporting it. So we'll not be able to hide behind anything now. And GPT was also, and OOP was consulted in crafting and putting that service delivery agreement. It's the projects that have been affected might not help them, but from just now, as from the 23rd of October, from the process and speed of delivery, we're then able to. And also within that SDA, which is also what we then implementing, member folks, is where we have a view of each financial performance of each project. And all invoices now, in maintenance included, are now on the electronic invoice system, which then says all of us will have a view in terms of what kind of infrastructure we are rolling. There will not be any transfer of money, but it will be paid as per the performance of each in terms of that work, the quality of work, which also assists, because that is a Department of Health managed process. So from an initiation point, because that happens within the department, so there is a lot of cooperative in terms of how we initiate, implement, and finally evaluate in terms of projects. Thank you very much, Chair.
Thank you very much, Dr. Maseko. Who is next? HOD? It's you.
Thank you very much, Chair. Good morning to yourself and to the members, as well as to the community. Chair, I just want to briefly talk to two questions that was raised. I think the one, the COO has already alluded to it as it relates to the vaccination of healthcare workers. Safe to say that there is a concerted effort to get all of the healthcare workers vaccinated, but the reality is that there is obviously vaccination hesitancy as well. If we look at the beginning of October, the percentage of healthcare workers that were vaccinated was just under 60%, and as of the 22nd of November, we're standing closer to a 70% mark. So I think the interventions, although slow, it is showing some level of improvement. Then, Chair, the question that was raised around the overpayment of salaries, I think that there is a challenge that is largely due to the manual processes that's still in existence within the department. I think the system to effect these terminations exists, but the process that gets initiated to get these terminations done is still manually based. And there's already a plan in place with the Department of E-Government to see how we can incorporate that manual process so that we can ensure that terminations does not get to E-Government late, which then results in overpayments. In the instances that's been reported, I know that HR has already started with a process to recover those funds. So in the short to medium term, I think to close the gap, we are looking together with eGov around how can we then automate those processes to ensure that we have adequate controls so that this does not happen again. Thank you very much, Chair.
Mr. Cave, before you go, sit there, don't move. Have you notified these people who are overpaid that they are overpaid so that they do not use the resource that does not belong to them? And is there any consequence management for deviation on supply chain management? Because I think there were two, this overpayment and the deviation. So we want to find out if there is any consequence management for the deviation from the supply chain management. But have you notified those who are home and have received more than they were supposed to receive? Because I hear you that you are still going to initiate a process to recover the resource. Thank you.
Thank you very much, Chair. Chair, all of the staff members who were terminated and were subjected to this overpayment, they were notified of the overpayments, and we've also started the process to recover those funds. So the notification has definitely gone out. In terms of consequence management, Chair, that is something that we will have to, I think that process has already started to make sure that this type of late terminations does not get into the system, which then results in this overpayment. The issue around deviations, Chair, I think there is something that my colleagues the CFO might respond to that specific one. Thank you very much, Chair.
Thank you, Mr. Cave. Now I think we welcome the CFO. Or is it you, Doc?
Thank you, Chair. It will be the CFO, and then after the CFO, there is Mr. Mutalatale that will speak to the initiatives to address the issues of vaccine hesitancy and getting the vaccine rollout going. Thank you, Chair.
I want to apologize. I think we must give Sir to say something. Please, you can say something now. They must give you the mic.
Hello, everybody. My name is Selailo Masipa. I come from Zergocom. I'm a chairman of the clinic committee in Zergocom. My concern coming to the infrastructure, the department gives a lot of people jobs, like giving them tender to repair the clinics, but they don't check after the contractors have done the contract. There's nobody who's coming to check. Like, for example, last year, the clinic was renovated on the roof. And the roof, when they were doing the roof, the contractor broke a lot of tiles on top of the roof. And it was leaking. Nobody came to check until I initiated myself to go and check on top, and I found a lot of tiles broken. Our managers are ladies. They cannot go and check on top of the roof that the tiles are broken. So the whole clinic was leaking, but the roof was done. I had to call them about 4 times, the same contractor, to come and recheck their job. But when I went up to climb the roof, I found out that a lot of tiles are broken, and are broken because of nobody's checking that people are doing their jobs well. So that's the one question. Another question is that with the clinic committees, that we wait a long time to be recognized in the clinic committees. You wait for appointment letter for a long time. Now we applied around September there. We're still waiting for the appointment letters. And again, that we are not recognized in the clinics. You know, when it came to COVID, people are tested, when the staff is tested for COVID. We, clinic committees are not tested the same as the employees. We are treated differently, as if that we are not working for the department. We need our clinic committees to be recognized by the health department, that even in small things, that you test, you are vaccinated. I had to wait for my term. I'm 50 years old. I have to wait until the 50 groups are coming to be vaccinated. But all the stuff, I'm there almost every day there at the clinic, but I was not allowed to be vaccinated. That is not fair, guys. That is not fair. That is not fair at all. What are you doing for the clinic committees? Again, there was supposed to be a meeting before the COVID started that we are going to come to speak about paying the clinic committees, but we were stopped because of COVID. So I need to know how far is the department of giving something to the clinic committees, because every day I go there, I have to wash, I have to get lunch. We are not giving anything, even food parcels. You don't even think about us, about even food parcels. It will be something that you're giving clinic committees something, but you're not thinking about us at all. At all. Thank you.
Mr. Masipa, which clinic is it?
Velcom Clinic.
Okay. Yeah, Dr. Masepko is here, and that issue that you raised, I think, it belongs to DID. And now, DID will check because DID ke yona e leng busy ka maintenance re tla o tla bolela le bona gore ba go addressa problem and then the clinic committee Dr. Zungu mo o tla e araba se wena o ka no dula fase re go kwele.
The last one, sorry. The last one is about the insurance. When are you going to introduce the insurance? Because we are seeing again, foreigners are coming to the clinics, especially Mozambicans. They bring their to the clinics, and then they come and collect medicine. They go to Protea Clinic, they come to Zerbecom, Protea Clinic. So with that policy of the insurance, people are going to be recognized well. Or we go clinicing everything, how I go clinicing everything. If Oskanga the tablets hang out. So I want to know when is it going to be introduced, that insurance entry national?
Oh, insurance ela ya nationally asa tlhoi thoma go bereka mara ge tlo thoma go bereka information e tla tla mo bathong mara bao ba bereka mmereko o ba tsweletseng a ke re Mr. Masipa ba go ya kwa le kwa ke gore re nita gore re matlafatse di clinic committee gore di re thuse ka gore lena ke lena le ba bonang le a ba bona le moni maabane kwa mara o ya kwa go ye nngwe clinic eo ke nagana gore department will do its best to ensure gore ba le thusa as clinic committees le kgone go addressa problem eo. And then tse dingwe tse ba tla ya go bolela bona le MEC gore ba ile ya pele bjang ka tsona ke nagana gore ba ka se be le dikarabo for tse dingwe tse o di botsisang mo today a ke re se mara ba tla ipolelela be ke no re ke at least some of these things I know gore e ya kwa mara re a leboga gore o bile le sebete wa bolela mo meeting ke tlo gopela ma'am ka mo. Yes sir, yes ma'am.
Sanibonani nonke endlini.
Yebo.
Mina ndingugogo uMamiya, ndibuya eCarltonville, Ward 13 eBlaybank. Ndiphakama nokuba ngumbuzo sisicelo zonke lezi zinto. iBlaybank Clinic inabasebenzi enabo. And iBlaybank ndicinga uba xa yakhelwe umphakathi lo ungahoywanga ngabasebenzi beclinic. Umphakathi xa uya ekliniki kufuneka ufike ume ngaphandle ungangeni before icleaners zigqiba uklina. Alright yena leyo bayabo umthetho. Xa sebengenile abantu kuyabanda kuyanetha. Kufuneka akuna shelter ukuthi mabazifihle khona. Akunanto nifuneka baphinde beme lo line bayimisiweyo. Abantu abasebenza ngabantu ababakhathalelanga bamile nje basaphunga basenza yonke into. Nihleli uzothi ngoku bufike ngo7 uyoze uhambe so uhamba ngabo12 okubungenile. Kodwa kwangena wena umuntu waziwayo ukuthi unozithethe yathethe uqalwa ngayo ukuthi uyosafa nguzibani bani. Ndifuna ukwazi ke ukuba iclinic le kanti umsebenzi wayo ayisebenzi ngabantu na lento inabantu ebakhetha uba mayisebenze ngabo mabakuqalwe ngabo. Okwesibili kwalicala le COVID abantu xa beyogoma bahlala ixesha elide kuthiwe omnye useselantshini akukho umuntu ozomenza nto unohlala khona apho niqokolelene akukho shelter kuyanetha abantu uzofika beyama okwegusha emabondeni kodwa baba manzi akukho umuntu oyikhathalele loo nto leyo. Amagama wabo abana name tag ababhala name tag xa ndibabuza ukuthi kungani lento ningenazo name tag bathi i-community yabazi amagama wabo. Ukusukela kukleka kuyotsho kunemunye umuntu onegama phayana ngusister boss oyebekwe igama lakhe kuphela. Abanye abantu abasebenzela nje nothanda kwavuka uzenzele ekliniki yaseBlaybank. Akunamuntu one-order ngoba noba nalama caregivers akhona uthi xa uthetha nawo ufumanise ukuthi angathi nale treatment lo uzoyithatha uzoyikweleta okanye uzoyicela bangakuhoya athi umuntu hayi yitsho kumna ndizakusela kwakho hlala ubalindi bama bakuzisela ayizi ngexesha lakho makude uyiphele ude wena uncambaze uhambe uyofuna i-treatment ngoba ufuna ukuphila. Bendicela ke ndingulogogo waseBlaybank ukuthi uhealth lo akakaye ayoyijonga laa ndawo angafowuni ukuthi ndiyeza avela atheleke nje uzofika abone ezimanga zenzekayo kulaa ndawo. Enkosi.
Lebitso la kliniki ke eng? Blaybank
Clinic.
Oh, okay. Thank you, ma'am. After ma'am abuletse alinya ku bulela something, alina something babang. Le sharp. Yeah. If all. Okay. they wanted
Ke
somebody
nna
to.
Tumelo, go go botsa gore go etsagalang if ever ke vaccinated ke sa kry vaccination number ya ka ke registerile online. O nkutlwile?
Can you repeat? Buseletsa
Okay.
potso.
Go botsa gore if ever ke vaccinated e be ke sa kry vaccination number ya ka. Go etsagalang ka nna na go tshwana fela ke tshwana le motho ke sa vaccinatang or ke tlo forced ke vaccinate number 2 gape. Like for instance, ke na le colleague e nngwe e yaka like gona no. O vaccinated mara ga na proof ya gore vaccinated ba mo file card le fela. And go re tsentse re tse di certificate tsa rona ta ke re go batlega se vaccination number ele. So ga na yone till now.
Re a leboga. O mong re tlile ho lena hore le re thuse ka ho botsisa. Re na le team mo ba tlo araba di-question wa bona ne. Ebile wena o tle mo o tlo fe Dr. Zungu lebitso la motho o tla o thusa because o tlo kry-ala motho. Go na le letsogo ka mo Isaac. Ke tsebile hore ba nyaka
Molweni ekomithini. Ngumama uNolfefe Mchingila lo uthethayo. Usuka eWard 13 eBlaybank eCarltonville. Ndenza ukweleka kule nto ithethwa ngugogo. Ekliniki eBlaybank sithi simiswe ngaphandle pha ufike mhlawumbe nge-7:20 kuzovulwa nge7:30. Ningeniswe ngaphakathi eyadini kubanda kunjalo nihlaliswe phandle phofu. Nisabe nihleli phandle kunjalo. Xa bevula nge7:30 ke ngokuba bezoqalisa usebenza abantu. Abasisebenzi kungena i-meeting. Meeting leyo izophuma izothatha i-hour. Mhlawumbi niqalisa usetyenzwa pha ngo-9. Baphinde futhi bathi xa ngaba mhlawumbi kuthiwe njengoba sibaninzi becothisa ke loo nto yabo bayenzayo ke bethetha ezo hours zabo ke kuzothiwa wena ubungavukelanga phofu kuvulwe udala umile apha phandle. So siyacela abantu abakwethu makhilungiswe laa nto yaseBlaybank. Mabayeke ukungena ii-meetings ngexesha bekufanele baqalisa umsebenzi. Siyacela at least i-meeting mayibe nexesha layo nemini yayo. Enkosi.
Thank you, re a leboga, ma'am. Go na le o mong hape o a nyakang go bolela something. Oh, re feditse a ke re ka community. Shelter, Dr. Maseko, is very important, is needed almost everywhere. In Kalafong, I think we have already received a complaint. There is too many people who are standing outside queuing to go to the hospital because there is no shelter. So there is a need for creativeness in most of our facilities. I think there was also a complaint from a clinic in Harankua where it is raining, people are standing outside. Dr. Zungu, creativeness must be done so that our people, they are having a shelter when they are waiting to be seen by the nurse and the doctor inside our health facilities. This is now the third I'm hearing it for the third time. So Rena, as a committee, we will try to make means to come to Blaybank Clinic. Me and her is our duty now, and members who are online, we will come. But this department must come before so that they come and correct what is happening there. So Dr. Zungu is going to respond and she will promise you something that will address the situation. And ngicela ukuthi athethe or akhulume asikabulela silungu because wena una that thing yaka mo ditsebeng. So but the shelter yona is something that is needed because population has increased. When the facilities were done is many years ago. Now we've got the population which is very big and people cannot stand in the rain, in the wind. There must be creativeness, please. We will come. You must just give us your phone number so that when we are done, when we are there, we can phone the two of you to tell you that we were there so that we reassure you that we do our work as a committee. I'm going to now hand over, but the name tag is very wrong for people who are working for government to work with people without showing their name tag. I think it's Patients' Rights Charter that also is encouraging everyone when they are working with people to have their name tag. Before Dr. Zungu, I think you said Mr. Mudiba was going to respond to something.
Yes, Chair. It was to just share what they are doing in terms of driving the reduction of vaccine hesitancy, both at the workplace and in the community. They have a program and they do it even over weekends.
Oh, Mr. Mudiba, over to you.
Thank you, Honorable Member. And honorable members in the House and in the platform, HOD and MEC in absentia and senior officials, and most importantly, community members. I think Honorable Mabunda did raise an issue in relation to beefing up our communication, and I want to agree with him that indeed we are in a space where there is information or campaign fatigue, that we've been at this for quite some time, and we do need to, from time to time, revisit our strategies. And hence, just recently we had an intra-action review where we were evaluating how we did during the first, second, and third wave, so that as we go forward, we can revitalize our strategies and be able to respond better. And as a result of that, a number of initiatives are actually in place at the moment as we speak. One of those initiatives is that we have rolled out a massive vaccination drive that is targeting workplaces, where we have made a call to employers in various sectors to actually avail their workspaces as vaccination places, so that we're able to then drive the campaign of taking the vaccines to people. And what we do with that particular program is that when we come into a particular area, as we have done in a community like this one where we are, where we've gone to the mining areas, and when we get there and we bring the vaccination, what we do is we also then reach out to communities that are nearby, so that we don't just vaccinate people in the workspaces, but we utilize that opportunity to also reach out to nearby communities, utilizing the infrastructure that is being provided by the employers. But over and above that, there are other programs that are currently underway where we have targeted places like your public transport nodes, places like your shopping centers, your malls, places basically where people congregate in larger numbers, as a way of taking what we call the pop-up vaccination sites to those particular spaces to make sure that we complement the accessibility of the vaccination program, which is currently accessible through both public and private facilities. And I think as part of then also increasing the drive is that we've also been looking at different initiatives, such as making transport available in hard-to-reach areas, to ensure that in those particular areas we're able to then mobilize communities and actually assist them in terms of getting to the vaccination drive. And I think what we need to then maybe highlight is that at the moment there is a campaign that is embarked upon by multiple stakeholders, which involve both government, private sector, and non-governmental organizations, looking at the festive period, precisely because of the point that Member Mabunda raised earlier on, that it seems like if you go around our communities, people are dropping the guard in terms of relaxing as if COVID is no longer there. We are aware of that, and it's something that we are working to address so that we can continue reminding all of us that COVID is still in our midst. We need to continue to observe the safety measures, in public places, sanitizer, keep a physical distancing. The type of meetings that they encourage really physically distance, ventilation, e nngwe dilo tse re dirang ke gore ke gona go rotloetsa batho gore a re yeng re yo tlhabang ga ile gore o ile wa tlhaba you can go back again for your second jab e file gore o tlhabile ka Pfizer ya mathomo ke yona ntho e kgolo e leng gore e tlo kgona gore thuša gore re mekamekane le bolwetse ba COVID-19 so tse dingwe tša dilo tše e leng gore ra di dia yona ba bele gore re partnerile le di cell phone companies bo Vodacom bo MTN bo Telkom ba e leng gore ba na le database ya di-client tša bona ba bereša database yo go romela melaetša to their clients to remind them of COVID-19 messages, of safety measures, but to also, from time to time, remind them. I'm sure what while in Tingamara Holokamo, by Longore, or maybe MTN or Vodacom or Telecom or Cell C. Ronaldo Quelungoro, gradi message, as about Ducha, Gradizena, Dugo Pocha, COVID-19, Dugo Pocha, Lekaware, Uyo Shaba. Milaja will grind you. Let's ignore Kimilaja Romelan le government, Reverigishana, Lebona ba the company Jokolo, telling Urdona, the company the politician. So those are some of the things that are already there. Lastly, honorable member, is that what we're also doing is that we are trying to also make use of the local media platforms to try and share messages utilizing those particular local media platforms. Reverigishana, the sector leaders in the community, or about to shake our ba tsamaishe melaetša mo community gobane re lemogile gore government ka boyona ga ena gore e ka kgona go fitlhelela go fenya bolwetse wa COVID-19 mara ga re berekišana le setšhaba re berekišana le mekgatlho e leng teng mo setšhabeng re ka kgona gore re fenye bolwetse wa COVID-19 ke a leboga.
Thank you, Mr. Mudiba. Can we ask the HOD?
Thank you, Chair. I will hand over to the CFO, and then I will close touching on some of the gaps that remain. Thank you.
CFO, you're welcome.
Chair. Good afternoon, good morning, good day. HOD through you, colleagues, good afternoon. Dumelang. My name is Lerato. I'm the acting CFO ya department. Chair, if you allow, I would want to just give a little bit of an explanation in a vernacular language, since most of the SCM issues are generally affecting small and medium enterprises. If that is okay with you, Chairperson?
You're welcome.
Thank you. Honale Butiso Ebutistwenke, Honorable Member Mabuda, on a plan ya department who improve our supply chain. Here lebella the business opportunities are defined, but we are below 30%, especially more di kgwebong tse di fiwang basadi or batho ba bomme le youth and le batho ba ba leng disabled. Bothata ba rena bo bogolo ke gore majority of the projects tse re nang le tsona di nyaka a certain type of skill or technology e leng gona. So we find ourselves having to buy equipments that are expensive or the equipment tsa go dura tse leng gore batho ba bo rena most of the time ha ba kgone di supplier. The company tse ngata tse nna leng di opportunity tsa go supply metšhini e ya health ke di company tse ownwang ke makgowa, and because batho ba rona they've been disadvantaged gale ha ro a ba kgone go tsenella into that market space. Saureka metšhini ya health. I'll just make a hypothetical example, Chairperson. We will need the X-ray machine. The company tsa rona ka bongata a ba kgone go manufacture metšhini e ya di X-ray. So re sa lebelletse gore di company tsa ka ntle ba re rekisetse metšhini e in the country. Ntho e one e re na leng yona as a plan ke gore metšhini eo ha e fetsa go rekiwa, the very big companies tse tshwanang le bo Philips le bo Siemens ba kgone employer the company tse ownwang ke batho ba bantsho for them to maintain these machines that they would have brought in the system. That would enable us to create the job opportunity for small companies mo Department of Health. Ntho e one gape e re boneng ke issue ya pricing. Batho ba bo rena he ba fiwa di business opportunity ba price di price tse kodimo. At the end of the day a ba qualify gore ba credit tender because ba lebelletse gore they want to make a big profit. Mare ge re ka no thoma ra re ha o submit the tender document wa ba le a way of saying mo ke a comply ke patela tax mo ke a comply ke tlo employa batho ba rileng wa khona le complete di document on time. It will then enable some of these small companies to then get opportunities. Honorable Mabuda, if you look into the structure or the procurement plan sa department, the procurement plan ya rena e re 70% of the project tse di leng ka mola di nyaka di health technology equipment. There's about 3.5 billion mola to buy this type of equipment. Mara ho lebella di project tse leng teng gape hona le mo re nyakang batho ba tla supplyang nama ya kgogo, nama red meat le batho ba providang di veg. Most of the companies tse nyane tse di tlang for these particular tenders, some at home, they don't complete the tender documents so you'll find but disqualify you on the basis of not completing all SBD forms. So we need to have a plan ya hore re rute batho ba rena hore the tender documents how di supply go nyakega eng, and that is one of the strategies or the plan that we want to put in place. Again, Johannesburg has got land we can use to assist small-owned companies, tsa basadi or tsa bomme or tsa youth, to bring themselves together as groups and liaise le department e tshwanang le agriculture. Agriculture will then assist hore ba lefe di seeds and all the other equipments so that the vegetables that you produce from there, you supply them or you sell them to health. So we are looking into plan eo ya ho integrate di plane tsa rena as health le Department of Agriculture. Hape ho na le department e ba e bitsang JEP, Gauteng Enterprise Propeller. Gauteng Enterprise e funda the small medium enterprises. So batho ba rona they are basically encouraged hore ba consult le JEP so that JEP can then assist them with funding and then they can get projects into health department. The last point on issue ya promotion of township enterprise, Chairperson, through you. The only way that we can fast track or ratsamaisa procurement ka pele ke ge re ka make sure our people are capacitated and knowledgeable on which projects they can then tap into. Department ya infrastructure is busy ka contractor incubator program on the projects tsa go tshwana le maintenance. So they now assist small companies for them to get to know which areas they can tap into gore ba kry business opportunity. Although ba re agela or ba re maintainela dipetlele tsa rena, we inform them of what needs to happen go health. He building ile so ile clinic re gona gore go DID re incubate or capacitate or train batho ba rileng in a community for them to can do small maintenance that is required. So DID e bereka ka di projects tsa rena as health to assist small companies in terms of developing them. Let me just summarize HOD on the issue of SCM deviations. The process of condonation, kore he gona le procurement e diragetseng ra contractor company not following SCM processes. Hangata, it's on the basis of agent procurement. O tlo kry-a le gore sepetlele a sena metsi or sepetlele sena le pipe e bestileng. So ha re requesta a service, it's on the basis of an urgent need for us to then prevent the worst from happening. So the majority of the deviations tse di diragalang, it's because there's an urgent need for us to procure the service tsa go tshwana le tseo. But important to note, key issue ya gore deviation most of the time happens as a result of the project tsa rena tsa supply chain di tseya sebaka. We know hore before re tla award a tender re fa a certain contractor re tshwantse re ise ko di auditorseng. So mosebetsi wa o isa project eo ko di auditorseng kwa treasury a se wa rena as Department of Health. So treasury ba na lo tseya sebaka he ba tshwantse ba audite that particular process or ba re appointele di auditor. So part of the reason why we deviate, and I give a good example ya consignment stock, re kry-a ile gore re procure 3 quotations whereas we could have gone out on tender. The process ya ho appointa di probity auditors e tseya sebaka, and we are left with no choice but to procure using 3 quotations. So condemnation also requires inquiries or investigations, and until process ya investigation e fela, we cannot now go to treasury and say condone. The responsibility of condone hape ke ya treasury as we know. And we are in the process of fixing that. Our investigations tse di diriwang ke SIU di setse di ela go fela le tse di diriwang ke department internally they are ongoing. We are hoping or process tseo di tlo fela before the end of the financial year so that we can submit our report to Treasury, request a condonation. Thank you, HOD. Thank you, Chair.
Thank you.
Sorry, one last issue on the clinics board. Honale lady community stipends. Question eo ne butsisa hore ro thoma neng go patela di stipends to community members. As department re setse re thomile ho lebellana le process eo and re tshepa hore before ngwaga o fela re tle be re he ke re ngwaga o fela ke bolela ka financial year gore before end of next year March we would have then paid what is required to all community clinic board committees that are due for remuneration. My apologies. We are looking into that as a department and we will ensure but they are being paid what is due to them before end of the current financial year. Thank you.
Thank you, CFO. HOD.
Ngiyabonga sihlalo ithuba onginike lona. Ngizoqala laphaya ngokubalula udaba obelike lwabuzwa umnumzana uFuchs umnumzana ohloniphekile ngendaba yokuthi izingane ziyalimala lapha ezindaweni zethu. Ukushona kwezingane ezindaweni zethu nokuhlangana kwalokho ne-COVID-19 into ebangele lokhu kakhulu ukuthi ngesikhathi sivalelwe siko level 5 kanje kuye kwaba nobunzima obukhulu emphakathini yethu. Sizobona ukuthi ngesikhathi unkosazana lo Adelekani ebeka inkulumo yakhe uye wachaza ukuthi khona izingane eziye zashona ezibhedlela zethu ngesimanga sesem. Isem ke ibizwa nge-severe acute malnutrition okusho ukuthi indlala esezingeni eliphezulu edlulele. Akuvamile-ke ukuthi ulindele ukuthi endaweni enjengase-Gauteng ungaba nendlala ekulelo zinga. Kodwa ngesikhathi se-COVID-19 isimo besisibi kakhulu, ububha budlangile, sakhona isimo sokuthi izingane zize zishone. Okunye-ke okukhona ukuthi siwumphakathi uma singazicabangela iy'ngane ikakhulukazi uma sikhuluma ngodaba lwengculazi. Uye wabeka umama Adelekani ukuthi iy'ngane yizona ezithinteka kakhulu uma sibheka ukuthi umuntu osetholakele ukuthi unegciwane odla amaphilisi liyathithibala na igciwane emzimbeni wakhe. Ey'nganeni-ke lokho kutholakala ukuthi akwenzeki kahle. Iy'ngane ziphila nalo igciwane futhi ziguliswe igciwane ngoba alithithibalisekile kahle. Kwenziwa yini-ke lokhu? Yithina abantu abadala kufanele sithathe iy'ngane siyihambise emakliniki. Ingane ngokwayo ayazi ukuthi inegciwane. Kodwa umama noma isihlobo esikhona ekhaya siyazi. Kubalulekile-ke kakhulu ukuthi sizisondeze iy'ngane ey'khungweni zezempilo. Ngizophinde ngihambe-ke ngiyothinta udaba oluye lwabekwa ngey'ndaba zasemakliniki. Uphendulile udokotela uMaseko ngalolo daba ikakhulukazi indawo zokulindela nokuthi kufanele siyibuke lezo zinto siyisheshisa. Kodwa ngithandile-ke umbono olethwe uGogumiya la ebebeka khona ukuthi ake sisuke nathi siphume lapha ema-ofisi sihambe siye emphakathini singasho ukuthi siyeza. Engakubeka ukuthi uma sibuzwa ngalezi zinto enisixoxela zona namuhla sizothola iripoti enhle ehlotshisiwe ukuthi konke kuhamba kahle, ikliniki liyavulwa ngo-7:30 babonwa abantu konke kwenzeke kahle. Nanguya-ke umnumzana uMalotana uwumuntu oselula-ke yena uyena ozokwazi ukuthi afike nje emakliniki la engashongo ukuthi uyeza ukuze abone ukuthi izinto ihamba kanjani. Kukhona-ke udaba obelibekiwe ngodaba lwe-NHI. I-NHI ke sibonile kuhanjwa la ezikhungweni zethu kuyotholwa imbono emphakathini ngokuthi thina sithini ngodaba lwe-NHI. I-NHI ekusondeleni kwayo uma sibuka imigomo yayo iyenza ukuthi umuntu nomuntu okhona eSouth Africa akwazi ukufinyelela ukuthi athole ezempilo ezikhungweni zezempilo ezikhona la ezweni lakithi. Lokhu ke okwenza ukuthi mhlawumbe thina abanye singabi mnandi ngokuthi nabangebona abalapha ekhaya bangabokufika nabo bazofinyelela kulezi zikhungo. Kodwa ke kuthiwe uma siya thina emakliniki asiyiphathe i-ID book ukuze sikwazi ukufakwa kulolu hlelo okuthiwa i-HPRS olwenza ukuthi amarekhodi ethu ezempilo angene lapha emshinini abe khona ukuze uma sifika thina konke okwethu kusheshe. Abangenayo ke i-ID kuzothi ukubalikhunyana kubona kodwa kusho ukuthi uMzansi ngeke ubasize bona. La eMzansi sonke uma sesingaphakathi siyanikezelwa ezempilo. Njengoba sibonile nasemjovweni ukuthi wonke umuntu odingeka ongaphakathi eMzansi uzojovwa ukuze sonke siphephe ezifweni. Kuye kwaba khona umbuzo ke oye wabekwa unkosazana laphana, angilibambanga kahle igama, angizwanga noma uTumelo. Kodwa ke uTumelo kuzodinga ukuthi ke sihlalo uma sesiqedile lana simbone sibe seceleni ukuze sithole i-ID book yakhe akwazi ukuthi simbhekele ku-EVDS inombolo zakhe eziconfirmayo ukuthi ujovile. Kuzoya ngokuthi ujove ngamuphi kumjovo. Uma ejove ngo-J&J uyobe ujovile sesingaphuma isitifiketi sakhe somjovo. Kodwa uma esathathe umjovo wodwa we-Pfizer ngeke sisheshe siphume isitifiketi sakhe somjovo. So sizomlindela ke lapha eceleni ukuze sikwazi ukuthi simelekelele sikwazi ukukhipha amarekhodi akhe aqondene nomjovo. Ngibonge sihlalo.
Thank you very much, Dr. Zungu. I think Gogo and my sister, Litlatla Kamo, Ritlo Nyaka di numbers rena from Gogo, and then Ausi Utlatla hu Dr. Kamo, Batleba Mufe, Abafedi direction. Thank you very much, honorable members, for participating in this meeting. On resolutions, there are no referred resolutions. On NCOP, there is nothing. On correspondence, there is nothing. Date of the next meeting is tomorrow, the 24th November 2020. We will be considering PSC report, Public Protector's report, medical legal cases, moral anguish, and TOP responses. For now, we thank you, honorable members. The meeting is adjourned. So for all of us here, we must remain seated. They are going to give you something to eat. But if you go out, it's going to be problematic. So I'm going to request that you remain seated and the food will be given to you. I want to thank you, community of Westonaria, for honoring the invitation. We appreciate it very, very, very much. Our officials from Department of Health, we must use that door now when we leave here, but there will be some refreshments prepared for all of you in that door. But the community, sit where you are. They will bring, but only Fadijo, Lili Moditulom, please, let's catch food.